Okay. Let's see if it's okay.
So good morning. My name is Terrell Corley, and I'm delighted to be here. I want to thank y'all for having me. I understand it's a hectic week since you guys have finals and all that. I want to thank the faculty and staff of Rose State College for allowing me to be here in such short notice. I also want to thank the faculty and staff of Indiana Wesleyan University, who will also be viewing this presentation at a later date and time. So about me, I've been a respiratory therapist for 23 years now. I graduated from the program here in 1995. So in that time, I've kind of seen my fair share of respiratory diseases and the burden that it can take on family members and patients, and the difficult challenges that we have in taking care of them. That brings us to the Healthy People 2020 initiative, and the Centers for Disease Control and Prevention puts this out to target diseases and health conditions for the next decade. So out of that listing of diseases, I chose to, obviously, I picked respiratory diseases to talk about. So we're all familiar with asthma as one of the respiratory diseases. It's chronic by inflammatory disorder of the airways. Usually people call it a hyperactive airway disease based on the coughing and wheezing and the way the airways react to cold air, like exercise-induced asthma. Allergic response is asthma. We also have COPD. We're all familiar with COPD as well. It's fully reversible. It's not fully reversible. Most patients with COPD are constantly short of breath. It's usually exposure to cigarette smoking that we all know. Some of the ones that we aren't all that familiar with, I'll actually go to this slide. The impact of respiratory diseases. Why do we talk about respiratory diseases? Why is it important? Well, according to the Centers for Disease Control and Prevention, there are more than 25 million people with asthma. There are approximately 14.8 million adults diagnosed with COPD, and there's 12 million people who have yet to be diagnosed. In 2009 alone, the annual cost of providing care to treat these diseases was $113 billion. That's quite a bit. That's not including lung cancer. The estimated cost from lost productivity, time missed from work, things like that, is an additional $67 billion. Feel free to stop me whenever you guys have any questions. The other respiratory diseases that most people aren't all that familiar with is that of idiopathic lung disease. And it's characterized by fibrotic lung disease of unknown cause, characterized by relentlessly progressive, restrictive ventilatory limitation, hypoxia, dyspnea, and cough. So most patients who have idiopathic lung disease are constantly fatigued, they're coughing all the time. It's usually a non-productive cough. It's just an incessant cough that is just debilitating. So that's what sends them into the ER or to their doctor's office to try to figure out, why am I coughing so much? Why am I so exhausted? Then that's when we start thinking along these lines. There are 9 different types of idiopathic lung disease. The most common of which that you will see when you start working around pulmonologists and in the field is idiopathic pulmonary fibrosis. These are other types of idiopathic lung diseases that are listed. The different pneumonias, the pneumonitis. There's another page, another slide of the various ones continue. Again, you see the pneumonitis, the pneumonia. Most people automatically ask, well, what's the difference between a pneumonitis and a pneumonia? Well, a pneumonitis is an inflammation of the lung tissue in the absence of an infection. And pneumonia, of course, is the inflammation with the infection, either viral, bacterial, hospital-acquired pneumonia. Some people always ask about sarcoidosis. This is where you get into the autoimmune responses and the autoimmune diseases. Sarcoidosis, a lot of people have nodules under their skin, different organs, liver, pancreas, kidney, and then they'll start seeing the scarring in the lung from that inflammatory process. Also asbestosis, I'm sure you've heard of asbestosis, you see the commercials. Here at the VA where I work, we see a ton of patients from being in the Navy, working in shipyards. I've seen patients in the private sector who are working in construction industry. They'll have a lot of scarring. Again, this is the continuation. Other types of lung diseases that are similar to idiopathic lung disease, silicosis, of course, bronchiolitis, again, another pneumonitis. Histiocytosis, that's another one that's similar to the hypersensitivity pneumonitis. These are usually people who have responded or react to dust, mold, different funguses. I've seen a lot of farmers have histiocytosis, hypersensitivity pneumonitis. Are there any questions so far? Again, we all know emphysema, but these are some of the ones that aren't as obvious. Again, pneumonias, the pneumonitis, bronchoalveolar carcinomas. Pulmonary hypertension is another one that we're starting to see quite a bit of, and that is, of course, when the pulmonary artery is constricted for a long period of time, then it impacts the right side of the heart.
What's the last one,
The
is it?
eosinophilic pneumonia. This is basically pneumonia that's caused by a lot of response to the eosinophils from allergic reactions, a lot of, again, grain dust, different environmental toxins that will cause the allergic response. And that allergic response that people get all the time will cause the scarring because you're constantly repairing the tissue. So that just builds up all that scar tissue. Kind of like if you have a scab. Well, if you have a scab and it continues to heal itself and then break down again and then heal itself, that's what goes on inside the lung. So these are the suspected causes of interstitial lung disease. Conditions that affect other parts of the body, again, the autoimmune response. Collagen disease, when I see this, I think of scleroderma. I think of rheumatoid arthritis is another one. A lot of people don't realize it, but people who have rheumatoid arthritis, it's not just the joints, it's also going on inside the body and inside the lung. Again, exposure to other agents, asbestos, tobacco smoke, occupational hazards. This is important too, because a lot of people don't realize it, but when they're working in the oil and gas industry, working around construction, farming, I always ask people, do you wear a mask? Oh no. And I'm like, well, all that grain dust and all that, dust and pollen and dander, that's going in your lungs. So over a period of time, it builds up and starts to break down in the lung and starts to repair itself, and that's where the scar tissue and all that inflammation comes. I've seen people in their 30s and 40s who are constantly short of breath and they have this chronic cough, and I'm like, what kind of work do you do? Well, I work in the construction industry. I'm like, So that's what kind of made me start looking at going into public health and epidemiology, trying to figure out why so many people are starting to have so many lung problems, and they're like 30 and 40. Population affected. I started to change this data because it says 75 or older for idiopathic or interstitial lung disease, but I think this number is a lot lower than 75. As they get older, of course, and the lung disease progresses, but I would venture to say different studies would probably say this number is more like 50 or 60. Of course, males more than females. The incidence talks about or is evident of the risk. So more males are at risk of interstitial lung disease than females. Again, when I start looking at occupational injury, I start thinking about, well, that's why this number is that high. And the prevalence, that's the male versus female. So what are the symptoms of ILD? Dyspnea, of course. They're just constantly short of breath, going to the shower, going to the bathroom, walking to get the mail. They're just chronically fatigued. They just can't catch their breath. The chronic cough, the cough is just incessant. It won't go away. It's debilitating. It's crippling. It just wears them out, spends a lot of energy. Hypoxia. You'll notice a lot of patients who have chronic lung disease. I'm sure you guys have seen the clubbing. Well, that's from the constant hypoxia that they have, so the fingertips will show it. Morbidity and mortality has an extremely high mortality rate. I've seen patients who come in and they've been healthy overall, all of a sudden they start getting tired, they're trying to figure out what's going on. And I've seen the diagnosis take them from coming in, next thing you know, you see Mr. So-and-so again, here it is, 3 months later, he's back again, he has an acute crisis, short of breath again, put him on steroids, you give him breathing treatments, high amounts of oxygen, and then next thing you know, within 2 to 3 years, he's like progressively worse where we can't hardly turn him around, and then you wind up having to intubate him. This is 61.2 and 54.5 deaths per 100,000 men and women respectively. Of course, the data is higher in men versus women. Most frequent cause of death, of course, is respiratory failure. They just give out. I mean, in spite of being on the BiPAP, off the BiPAP, IPPB, all the things that we do to try to treat the condition. They'll do a stand in the ICU, then we'll finally get them to the floor, then they're back in the ICU. Next thing you know, you're reintubating them. And that's, like I said, basically it's just chronic respiratory failure. It accounts for 80% of all fatalities. So why do we screen them? Well, we want to try to properly diagnose them early enough to improve the quality of life. And it's also to differentiate between other types of lung diseases. As you saw from the previous slides, there are a lot of diseases that will mimic interstitial lung disease. So how do we know? How do we figure out whether or not it's interstitial lung disease? So the sooner we can figure that out and diagnose them, the better off we'll be. So the methods of screening, I included one of the dyspnea questionnaires in there. Usually there's a 1 to 5 Likert scale. That one is a 0 to 4. With 0 being not bad, mild, 4 being severe. The chest x-ray is important. This is high resolution CAT scan, that's also important. The FVC, most patients' FVC will be approximately 60 to 70% predicted. And then it decreases from there. We always bronch them, do a biopsy. Of course, we get a blood gas, and when they come to the ER and they're short of breath, we'll just do a blood gas on them. See how toxic they are and see what their CO2 is. This is a slide of an x-ray. And I'm not sure you can see it on your printout, but this is kind of what we look for. It's usually in the bases. So when you listen to them, you'll hear crackles in the bases. And then you think, well, this person is not all that chronic, so why do they have crackles in the bases? This is the high resolution CAT scan, and we look for this honeycombing appearance, and again, it's in the bases. That's definitive of ILD. So the gold standard is surgical lung biopsy. Most people are familiar with the term VATS, that's video-assisted thoracic surgery, where they go in there and make the incision, put the camera in there, get some tissue samples, send it to the lab. Also, again, the CAT scan. So between the biopsy and the CAT scan, we can definitively say, yes, this is interstitial lung disease. So how do we treat it? Once we know that, yes, this is interstitial lung disease. Oxygen therapy. These people are well above a cannula. So I automatically start looking at Venturi masks, oxy masks. Are they familiar with oxy masks? Have they seen oxy masks? I love oxy masks because most patients or most people in hospitals, they automatically get the simple mask. And it's easier to use an oxy mask where it can be titrated up or down versus a simple mask, a Venturi mask, a non-rebreather. So I automatically go for an oxy mask or higher amounts of oxygen. Positive pressure ventilation. I'll go back to oxygen therapy, I'm sorry. We also use vapor thermoline. These patients require 40 liters of oxygen on 70%, 80% on a comfort flow or vapotherm. Positive pressure ventilation, BiPAP. BiPAP's the friend for patients who have ILD. Mechanical ventilation, of course, when they're impending respiratory failure, worker breathing, can't be relieved from a BiPAP, stick them on the vent. Pharmacotherapy, we always give them bronchodilators, and that's just to relieve the worker breathing as well, dilate the airways. Antifibrotic medications. This is a good drug in the sense that it helps to break down that inflammation from the collagen and all the repairing. This is a continuation of the treatment. Pulmonary rehab. Pulmonary rehab is important because it increases the quality of life. It improves the quality of life. Increases exercise tolerance. Some patients, when they start pulmonary rehab, they still get short of breath when they start walking, but as you can see, when they progress through pulmonary rehab, they can walk a little further, they're not as winded. Teach them pursed lip breathing, other techniques that will aid them to keep them from expending so much energy. Lung transplantation. That's a big one because that's really the only cure. The only problem with it is a lot of people don't live long enough to get a lung transplant. So that's when we start thinking about palliative care. So it's basically to transition them to decrease the stress from living with the condition and also to help the family members to cope with the disease process. Emerging treatment. This is noteworthy because thalidomide kind of had a bad rap back in the day. Say back in the day. Because in the 30s, 40s, and 50s, they used thalidomide to decrease nausea in pregnant women. However, in the first trimester, it did decrease the nausea, but then they noticed when women delivered, they had a lot of birth defects. So that's why they pulled thalidomide off the market for treating nausea in pregnant women. But then they realized that thalidomide had other properties that were beneficial. So researchers designed a 24-week double-blind study, and they gave 98 participants randomly assigned. Some of them received the treatment and some of them didn't. Some of them got both treatments. This was the mean age, 67, and the mean FVC was 70%. The quality of life scores for the cough index, they improved significantly with thalidomide. And overall, the quality of life was improved in general. Prednisone, of course. Prednisone helps with the inflammation process. These immunosuppressive agents are also important because of connective tissue disease. And we're all familiar with acetylcysteine. A lot of therapists ask, why does every doctor order acetylcysteine? Well, this is why. They've noticed that it does improve lung function. So even though this person might not be coughing a whole lot and we might not need this mucolytic, Mucomyst has other properties that are beneficial. So this is the value to public health. The burden of lung disease is increasing rapidly. There's a rising number of hospitalizations post-diagnosis because they're in and out. They're back in the ER, they're discharged, they're in the ICU, back on the floor. Within 3 weeks, they'll be back. So as you can see, the healthcare resources are just stretched behind this patient population alone. Total cost for patients with idiopathic pulmonary fibrosis was $26,000 per person a year. That's a lot. And this data is basically a decade old. So the sensitivity and specificity. The sensitivity tells how significant the diagnostic test is, how it's able to positively identify interstitial lung disease. The researchers performed a study to evaluate the use of biopsy versus high-res CAT scans in diagnosing idiopathic pulmonary fibrosis. All the patients suspected of having the disease were entered into the study if their condition permitted. So we had 8 referring centers, and 54 of 91 patients received the diagnosis. So this is pretty good. And as you can see, it was higher when it was reviewed by a specialist like a pulmonologist or radiologist. Bronchoscopy resulted in sensitivity of 85%. Specificity, sorry, is 43%. And that's the ability to negatively weed out people who don't have the disease. So in a comparable study evaluating the use of high-res CAT scan versus tissue samples, the results were as follows. Again, the sensitivity was 78.5. This is the positive predictive value of 88%. That's pretty good too. This is the proportion of people who were positively diagnosed. That brings me to the end of my presentation. Are there any questions? Thank you all.